On behalf of the Pennsylvania Patient Safety Authority, I'd like to welcome you to this web conference titled Norovirus Prevention, Tips from the Toolkit. My name is Rick Kondravi, and I'll be your moderator for this program. Now I'd like to introduce our speaker for today's webinar, Sharon Bradley. Sharon is a registered nurse and board certified in infection control and epidemiology. She is a senior infection prevention analyst with the Patient Safety Authority. She has practiced for over 45 years in clinical, education, risk, administrative, and patient safety roles in both acute and long-term care. Sharon has authored multiple infection prevention and control journal articles and has provided educational programs on infection control topics at local, state, and national conferences. She serves as the director and chapter legislative representative on APEC Philadelphia and Delaware County Boards of Directors. Sharon, now I'd like to turn the program over to you.
Thanks, Rick. Good morning. Good afternoon, everyone. So today we're going to talk about something fun, norovirus, which has tortured many of us through the years. So our talk today is aimed at providing you with some new tools to deal with what I like to call the scourge of these really nasty annual attacks from this very contagious virus. So we're going to help you differentiate norovirus outbreaks as a subset of all gastrointestinal illnesses. As you know, our criteria has changed to allow us to do that. We'll go over the components of a norovirus prevention and rapid response plan that includes all of your interdisciplinary team. And we'll give you some tips on how to translate the evidence-based interventions we're going to be talking about into practices that you can translate into action at the bedside to help prevent norovirus. So this table shows the number of norovirus reports submitted by the Pennsylvania long-term care facilities for the last 3 recent norovirus seasons. The norovirus can happen at any time of the year, but it happens mostly in the wintertime. Now, it's interesting that prior exposure to norovirus appears to provide strain-specific immunity for only a few months. So this explains, of course, the high rate of repeated infection. So looking at this table, you can see we have intermittent cases in June, July, August, and September for the last 3 seasons, as indicated by the white shading. And the norovirus outbreak season is started as early as October and lasted through May, and that's the light gray, or if you're looking at the actual slides, it's coded in yellow. Now, the months that we have shaded in red, the darkest ones on the slide, this demonstrates the time of year that norovirus burden is at its highest in Pennsylvania long-term care facilities, since this is our data. So in April of 2014, in accordance with changes to the national standards, the authority revised the long-term care criteria for identifying and reporting gastroenteritis using the revised McGear criteria. So there's a new gastroenteritis subcategory that allows you to do detailed surveillance and reporting of norovirus cases separate from other types of gastroenteritis. Now, this is the first we're looking at this data since the standards were revised. So we're taking a fresh look at the incidence of norovirus in our long-term care facilities. The new criteria allows you to analyze the number of cases and outbreaks of norovirus as well as apart from other types of GI infections. So we're going to start with a poll. You know how you love polls. So on the right-hand side of your screen, as earlier explained, you'll see the polling questions. They ask, how often has your facility suffered from a norovirus outbreak? Now, some facilities, of course, suffer from a norovirus outbreak every year, and hopefully those people are on the line today so we can help you not suffer that. Because of different strains of norovirus, there can actually be more than one outbreak in the same facility with the same people more than once a year. Less than every year is what a lot of people experience based on how virulent the strain is. Lucky people who never have a norovirus outbreak, we'd all like to hear from you. And hopefully everybody who's on this call is the person doing surveillance and tracking norovirus in your facility. But if you're not, then not sure would be your answer. based on the data you provided to PACERS, we can see that multiple facilities still suffer from norovirus outbreaks every year. And out of the 222 out of 700 long-term care facilities that reported norovirus, 82% had norovirus clusters that met the CDC's definitions of an outbreak. Now, the longer outbreak was reported over the course of the longest, lasted 27 days and included 138 events. So feel bad for that facility, and hopefully this program will help with that. So I see that we do have some results, and it looks like we have kind of an even Steven. We have some people who aren't sure, and some people who never. So we're kind of all over the place with people experiencing norovirus outbreaks, and that's really interesting. So hopefully the information we give you, those of you who are having these outbreaks, can help you prevent that, and those of you who don't, to make sure that you won't, and that your programs are strong. So thank you for that. And so we'll go into defining a case of norovirus. As I mentioned, that we use now the revised McGear criteria. So norovirus infection is basically characterized by an acute onset of nausea and vomiting, watery but non-bloody diarrhea. And sometimes these residents do have abdominal cramps and typically a low-grade fever. So generally, symptoms begin 12 hours to 2 days following exposure. And because norovirus is a self-limiting disease, there's no antibiotics for it. It resolves spontaneously within 24 to 72 hours. And as any of us who've had norovirus know, they're kind of like the worst 72 hours of your life. So when you're actually doing surveillance and looking to report these cases, you have two different criteria you can use: the diarrhea and or vomiting with negative C. diff results, and a stool sample that you got tested that's specific for norovirus, or the same symptoms plus, instead of a stool sample, you had the presence of all four Kaplan criteria in the absence of doing the lab. And we're going to talk about Kaplan in a minute. So just want to reiterate that diarrhea is characterized as 3 or more liquid or watery stools above what's normal for the resident in a 24-hour period. Vomiting is 2 or more episodes within a 24-hour period. So the testing of diarrheal stool by real-time PCR, which doesn't get done in your facility, if you're a long-term care facility usually, this allows for a rapid and very sensitive means of detecting and differentiating the strain of norovirus, so we kind of know what we're dealing with, especially in years where the strains are particularly virulent. And so while these molecular methods do offer a way to establish the etiology of norovirus, these diagnostic tests may not be available in some of your facilities, or they're not really worth doing because of the time delays to actually get the results. So in that case, here we go. Okay. So Kaplan's clinical and epidemiologic criteria was developed before the molecular tests were available. So it can be used to rapidly identify norovirus outbreaks. And this criteria continues to be very useful in identifying norovirus outbreaks where these diagnostics are not acceptable, or you want to get as much information as you can early on so that you can put your preventive measures in place. So the Kaplan criteria requires 4 different things. Take all the people who are vomiting, and you would be considered an outbreak if you have vomiting in more than half of the affected persons. The mean or the median incubation period of that 24 to 48 hours, and the mean or median duration of illness lasting for 12 hours up to 60 hours. And this is the one that confuses people. It says no bacterial pathogen identified in stool culture. We get a lot of calls to our help desk. What does this mean? It means 2 things. 1, you didn't do a stool culture, which happens a lot in long-term care, or you did one and there was no bacterial pathogen found. You didn't find open parasites, you didn't find salmonella or shigella or any of those other things. So, that's hopefully that clarifies that for some of you. So the consideration piece should be given to the person's exposure history and the incubation period. So some of the questions you can ask yourself are, is norovirus infection confirmed anywhere in the facility? Were the suspected cases of norovirus exposed to confirmed cases of any kind of gastroenteritis in the last 48 hours. You want to investigate if the number and location of symptomatic patients are linked somehow epidemiologically. You also very much need to see if there's another pathophysiologic basis for this person having these GI symptoms. You don't want to just assume that they have norovirus. And of course, any clinical test like this clinical test using the Kaplan Criteria can be supplemented by lab testing to help confirm it, but that's not required. So what about an outbreak? Well, an outbreak of norovirus is defined by the CDC as an occurrence of 2 to 3 or more similar illnesses, where staff or residents have vomiting and or diarrhea within a 48-hour time frame. And these symptoms would be resulting from a common exposure that's either suspected or laboratory confirmed with norovirus, because we work with both. So who's at risk? Well, noroviruses spread rapidly in healthcare facilities. They're really hard to control because of a very low infectious dose. They're easily transmitted. There's a short incubation period. They live long and prosper in environmental surfaces, and there's not that long-lasting immunity just isn't there for us. So when you're looking at developing your program, you want to address these factors, the viral, the host factors, and the environmental factors. So I want to talk a bit about viral factors. It's estimated that exposure to as little as 10 viral particles contributes to the ease of sustained transmission of norovirus. That patients or residents with incontinence, hygiene issues, they can significantly increase the burden of the viral load all over your facility's environment. These viral particles are excreted in very high numbers in feces and vomitus during the first 48 hours of illness, but people who are recovering from norovirus can continue to shed some viral particles for 2 or more weeks after symptoms subside. So where our standard precautions come into play. Reinfection and outbreak reoccurrence can be due to the repeated introduction of one of 25 different strains of norovirus. And so the high rate of repeated infection, whether it's in the elderly or people at risk or anyone, is due to this exposure to norovirus and the strain-specific immunity lasting only for a few months. And when we talk about host factors, norovirus outbreak can spread quickly in communal living settings. So whatever kind of, even if it's an assisted living or an independent living, there's still a lot of people living communally. In other kinds of healthcare facilities, people get together in groups for various reasons. It is just to line them up somewhere because you have to watch them to make sure they're not falling down. But, shared public bathrooms, hall bathrooms, semi-private rooms, group dining rooms and activities, social events, those kinds of things are areas in which norovirus can thrive. It can also happen by eating food that's prepared by food handlers whose hands are contaminated and who are ill, but, make themselves come to work anyway. You can also get it from consuming shellfish or water that's contaminated with raw sewage. You don't have to be able to see it for it to be contaminated. Well water can go bad, septic tanks leak, chlorination failures occur, and those are the kinds of things that you want to ask your maintenance people to keep an eye out for. Oral contact is also a risk factor because contaminated body fluids can contaminate your skin, the environmental surfaces, and again, even if they're contaminated with fecal material or vomitus, you may not be able to see, may not be enough to actually visualize it. The majority of norovirus outbreaks involve primarily person-to-person transmission. So this is frequently on healthcare workers' hands or the hands of residents who are ill and not washing them. And then they can transfer that pathogen. Their studies show that these pathogens are so strong that if you get it on your hands, you can transfer it to 7 different surfaces, one after the other. So it's not just the one and done in that same room. It can even happen when they leave the room. So vomiting patients or residents or even staff can disseminate the virus because it can be through airborne transmission. So what happens is the vomitus, wherever it happens to be, can be aerosolized, and that can result in droplets that people swallow. And so that's why you want your housekeepers to take protection as well while they're cleaning up, whoever's cleaning this up. So the environmental risk factors are really interesting when it comes to this virus because it can survive temperatures from freezing to 140 degrees. They're able to survive and continue to cause infection after long periods of time, either in water or on surfaces. Surfaces that are soiled with aerosolized vomit droplets or contaminated hands can make your outbreaks just go on and on and on. So some outbreaks have been traced to contaminated computer keyboards. And one that I recently read about was distinction with the food staffers, the food service workers. They wash their hands and then they rinse fresh vegetables in the same sink. Anywhere you go, hand washing and food preparation should not happen in the same sink for that kind of reason. And so this organism is also resistant to a lot of disinfectants and that we use on environmental surfaces. You want to make sure that you're using an EPA product that will kill norovirus or bleach. I like this little guy. I can't make the hamster wheel move, I don't think. But, if you can just picture him running and running and running, this is your administrator. And healthcare facilities are the most commonly reported settings of norovirus outbreaks. And like many of you, I've been the IP in both a long-term care facility and an acute facility overrun with norovirus. So I developed this toolkit based on lessons learned and some new evidence-based practices that were recently published by the CDC for the control of norovirus. So these types of outbreaks often result in significant financial and operational burden to facilities. Healthcare facilities might not be prepared to manage a large number of infected patients or residents, and the outbreaks can be prolonged. Sometimes they last months. If you just kind of let it go through and hope for the best. Staff calls out, they need sick leave, overtime, and that'll cost money. You need additional healthcare supplies, linens, commodes, cleaning supplies, all those things cost money. And of course, your healthcare facility then does experience financial losses, especially when your unit or your whole building are temporarily closed until the virus can be controlled, or you just let it run its course. Add to all of this the knowledge of the impending doom that norovirus may strike your facility again next season, and hopefully that's why you're here today. So the big question is, what can you do differently to help your interdisciplinary teams get off the treadmill, get your administrator out of the hamster wheel, and stop norovirus dead in its tracks before it becomes an outbreak next year? So, good news. Patient Safety Authorities revised our website, so the links you may have accessed in the past have been changed. Here's a snapshot of the Norovirus Toolkit in the new PSA website, and you can see there is a link on this slide. So the entire Norovirus Toolkit is available from the landing page, also under patient safety topics. So we put norovirus and hand hygiene up there. I think they're just going to keep them there. Usually they kind of rotate those, but it seems like this is a big problem. As you can see from the data, we're not doing a whole lot better. So something's got to change rather than just collecting numbers. So what's in the toolkit? Well, first we have the norovirus advisory. It's called the Controlling the Annual Threat of Norovirus Gastroenteritis. That was written in 2010, actually with our old data, but there's a lot of information about the science behind this and the background you need to put your programs in place. There's also a recorded webinar on our website, again, which is older and will probably be replaced by this one. There's a norovirus preparedness checklist, which I'm going to go over with you in detail, as well as the case log and the process and measure worksheet. We have a short video on YouTube that takes 5 minutes, maybe not even that long, that you can use to kind of get the ball started in your building, get people to pay attention. And there will be some new materials added to the toolkit. I'm doing an update because of the new data, and that advisory should be out either June or July. So this should be something that you want to bookmark and go to on a regular basis. And we want to find out from you to really help with guidance and education. Obviously, that's what we do here. We don't just collect your data. We want to do something about that to help you not suffer from this anymore. So we're interested in which of the tools that are listed here best describes the ones that are used in your facility, not only to prepare for, but also to control norovirus. And so we have, of course, the Norovirus Toolkit, which I just showed you. And the CDC also has Norovirus Toolkit, which is mostly links to resources, other resources, but they do have, that's where the most recent science is about control of norovirus. Some facilities have corporate tools for collecting these kinds of things. If your facility doesn't use any specific tools, that's good to know as well. And health departments usually, sometimes all people use is the line listing that comes from your local health department when you call them to help you if you have a bad outbreak. Thank you. And so when we talk with people on the help desk, it's clear that the infection preventionists are increasingly frustrated with the perceived inability, to control this annual problem. So every case has to be reported individually. It takes a lot of IP time. So my experience with outbreaks both in the acute and long-term care settings is what prompted me to develop this program to get control of the virus before it could cause too much damage. So I'm happy to be passing on this to you along with the new research that's available. So we have our responses, and it looks like pretty much everybody is using the CDC tools. So some people still don't have tools. The health department line listing is useful. So take a look at, we're going to talk through these tools and show you how to use them, and you can decide if they will help you enhance the program that you do already have. So first, we're going to move on to the components of the Patient Safety Authority Toolkit. And don't worry about how small this is, because I'm going to break it down into parts for you. So the key component of an outbreak prevention program is that healthcare facilities and their staff, your staff, are better equipped to respond to norovirus when you have protocols in place for preventive measures well before norovirus season, which is why we're doing this in the summertime, because if you don't have a program, or you need to update your program, you have the whole summer to get it ready. So the elements of an effective protocol include tasks that are needed to prepare for and manage and report outbreaks of norovirus. And so your outbreak control can be really greatly enhanced by the rapid action of your interdisciplinary outbreak control team. And this team is meant to advise and coordinate timely implementation of measures to control the outbreak. And we're calling it interdisciplinary versus multidisciplinary because we want you to work together on this project and not just send everybody off on their own little silo to do what's good for their department. So the first tool is this pre-season assessment, and this is a sample checklist designed to assist you to assess your facility-specific preparedness plan activities. So you've been using all kinds of different tools, but this can help you. It's straight from the guidelines, all evidence-based. We didn't make any of this up. So you can kind of check off and see, do you have these things in place? Do you have a policy? Do you have a goal? Do you have a plan? Do you have education? Who's responsible for it? Are there resources set aside for this? All of these things, when you just answer yes or no, you need to take into consideration. So this itemizes the interdisciplinary tasks to implement an outbreak prevention program or enhance the one that you have. And so when you're developing a facility-specific plan, you want to consider that all the elements that are here, that there are elements that address the host, environmental, and virus risk factors that we went over, the best methods to actually identify an outbreak using the information that we just talked about, and what specific interventions do you have in place to prevent or contain GI outbreaks. So this kind of a checklist has three parts. It has a task to help you assess the facility level of implementation of each practice that is listed. And we also added who you're assigning this to, because this is not just, oh, well, this is nice, and give this to your infection preventionist and say, let me know how that worked out. I'll support you. I think to be truly interdisciplinary, people need to know what's expected of them and how to do it. So, and of course, the date that it's actually done. Looking at this tool in detail, norovirus control requires a proactive interdisciplinary process for each of the tasks in this pre-season assessment. If you don't have this type of program in place and you suffer from repeated bouts of norovirus, now's the time to update your plan. So you need to have a norovirus outbreak policy that's consistent with the CDC guidelines. We do have that in the references for you, so you can just go to the link to look at them. You need an outbreak policy that describes each individual staff level's responsibilities. What does nursing do? What does social service do? What does maintenance do? I mean, this is not just a nursing issue. What does administration need to do? The outbreak policy should have a clinical definition of a norovirus case and an outbreak, which we gave to you earlier. And, continuous surveillance for symptoms of acute gastroenteritis disease help alert the staff to respond to a surge of a cluster of cases or about what's average for your facility. You don't want somebody saying, you know what, I meant to tell you last week that we're having a lot of diarrhea over here in this unit. It's like it's been running rampant for a whole week. It's a lot harder to get control of it. So you really need those people to kind of help you as soon as it starts. So other preparation activities include having a system to record outbreak cases and symptoms, and a daily log is really the best for that. Now, those of you who use the health department tools, they usually provide you with some kind of log that they like. And I'll also show you a sample of one that I like to use. Certain specimens will have to go to the State Bureau of Labs if you don't have the ability to do the PCR testing, molecular testing in your facility or at your lab. So you want to make sure you have a system to get those specimens out while the person is shedding a lot of virus in those first 48 hours. Your educators need to have some sort of a staff training program. Use these slides. It can really help, and I'm going to show you something really cool at the end of this program that will help you with that. So in-services also need to go to residents, especially if you have a facility that you deal with different levels of residents, that assisted living, independent living kind of scenario. Sometimes you have nurses and physicians who live in those kinds of units that can be really to help you for resident council. And of course, it's important to have some planned ahead signage that people will post that can be done, that you don't have to need a nurse to go post things on a door. Okay, so other preparatory activities include having some sort of a family notification letter. Norovirus is norovirus. You could write the letter ahead of time. What the social service and admissions and your administrator want the public to know, because they could just give that to a newspaper. So you want to be careful about what you're writing, but have something done ahead of time so it can just be printed and sent out to people. Having a rapid response communication plan really involves a way to notify everybody who's involved in helping with this or who has a need to know. Sick time policies. We talked about how much that costs the facility, but we still can't have people in the building working who are vomiting or having diarrhea, or at least 24 hours after that all stops. You want to make sure that you exclude ill staff members from work for a minimum of 48 hours after their symptoms go away. And, you can make sure that non-essential staff like students or volunteers, don't let them work in areas where you're having an outbreak of a gastroenteritis problem. So there should be some sort of protocols for that. You also want to have that inventory system. We talked about how much it costs to do this. What do you need to get through this, and what do you need more of? And as norovirus season approaches, when is your people who handle ordering and supplies and inventory, when do they need to know to start getting these things together? The last is having a protocol for the patients or the residents or the staff to be cohorted. And what does that mean? So this is a protocol in which staff provide care for only one group of patients on their ward. So they either work with symptomatic patients, or they work with people who've been exposed but they don't have any symptoms yet, or different people work with people who haven't been exposed. And they don't move around back and forth between this patient cohorts, because that just spreads it around. So it takes some thought to figure out how you're going to do this. And if you wait till it's upon you, it really doesn't work all that well. So what are some basic precautions that you need to have in place now? So you want to make sure everybody understands what contact precautions are and how you would use them for a gastroenteritis outbreak. Sometimes it's good to just practice. You want to make sure you have enough toilet facilities for symptomatic patients, and you have a good system in place to really watch if people are washing their hands. There was another advisory on hand hygiene, which you can get when you land on our face page and pull down patient safety topics. And this could really help you if you need to improve hand hygiene compliance. Now, it's important to have an outbreak policy that talks about the frequency of environmental cleaning on affected units. This should be done like regular cleaning if it's once a day. In the people where people are exposed or where they're actually symptomatic, you want to enhance that cleaning to at least twice, if not more, times a day, depending on how often you think the high touch, the bed rails and the handles and the light switches and all get used. And that'll be doing, how often you do that would be how often those kind of areas are used. So it's important to use that disinfectant, like I talked about, that's approved by the EPA, and everybody knows where it is, because things happen at 11 o'clock at night and 3 o'clock in the morning, and everybody needs to know that norovirus doesn't take a break. So, and also soiled linen it's important to talk about. So we don't use bags that are dissolved in the washing machine anymore. You don't have to do any specific types of laundry. Just make sure that it's not dripping when it's in the bag. If you do have an outbreak, you did all that and you still have an outbreak, because there's not a lot of cases in an outbreak. So if people tell you right away that it's happening, then you want to jump right into this rapid response plan. Again, if everybody knows what they're supposed to do, they can just go do it. Your outbreak team meets, say, okay, you all know what to do, let's just double check. Okay, everybody go do it. Certainly as an infection preventionist, early detection of cases, but if nobody tells you, so you need the nursing staff and the people who are handling employee health to really tell you what's going on, because you can't do surveillance on something you don't know about. Contact precautions, again, how do you use those? Do some practice. The hand hygiene, what do you want to do differently during a norovirus outbreak with monitoring hand hygiene? Again, you can have different people monitoring this. The enhanced environmental cleaning is something you need to work out with your AVS person for what they would do during this outbreak, as well as linen handling, and using those enhanced precautions. So the key to controlling the transmission of this disease, you want to reduce the magnitude of cases that you have, and certainly not get to a full-blown house-wide outbreak. So you need that rapid, simultaneous implementation of these multiple control measures. Here's the enhanced precautions. Again, you see this is still part of a pre-season assessment, something you're going to do now to make sure not only does the IP know, you need everybody else to know what the protocol is to suspend group activities in the event of a widespread outbreak. It could happen over the weekend. Mine happened when I was on vacation and came back to a giant mess. So the outbreak policy needs to include what you're going to do to close patient care areas, not admit or transfer people back and forth to the hospital, keep visitors and families out of your building or out of specific units. Who gets to make that decision? Probably not the infection preventionist unless you're the director of nursing. Who makes that decision? That needs to be part of this plan and part of your protocol. Who approves that plan? Does the medical director have to approve it? Who do you have to tell? Well, pretty much everybody. But there's different levels of communication for different kinds of people. So, you need to address late shifts, weekends, holidays, and all of that when you're talking about this enhanced precautions and closing units. So this is another one of our tools. This is the Acute gastroenteritis Outbreaks case log. And you'll find this, of course, on our toolkit as well. Facilities can use this sample log to help determine common factors, but any acute GI outbreaks. It's meant to collect information in a timely, reliable, and organized method. That means that it's not the IP who comes in every day with their piece of paper and tries to fill this in. This is 24/7 a document that the nursing staff needs to know how to use on all the shifts. So let's look at that in a little more detail. And again, this is probably similar a lot to what you get in your health departments, but I wanted to go over the different topics in here to make sure that you're getting all the information that you need. So this first one, of course, is just the case information. I turned it around so you could read it, with the people's, rooms and date of birth and all of that. The shift of onset is kind of important, and the date that it's onset. I think she started yesterday, but, they didn't write it down. People need to know that this is really important. So the second part of that log is the description of the illness. So here we're checking off, again, date of the last episode and the shift. of nausea, vomiting, diarrhea, blood in the stool, cramps, fever, headache, any of those things. And the next part of this is the tests that were done. So not only do you see a stool culture here for norovirus, but you see one for ovum parasites, C. diff, salmonella, and shigella. You're having a big outbreak. You could have a mix of different things going on. And, of course, we don't mention dietary problems here, but if people all had carrot and raisin salad for dinner, it could just be their problem. We also have the outcomes. We want to know if somebody went to the hospital. Did they die from dehydration from this? That would be pretty bad. Or if it's an employee, how many work days they missed, because this is for both. So we also have outcome and process measures that are important for you. So mostly I hear, oh, yeah, we had an outbreak. It was a pain in the neck reporting everything to Pacers, but now it's over and I can go on to the next thing. We need to learn from these outbreaks, to learn from what's happened in our facilities every year, not just for norovirus, but for everything. So we made sure the outcome and process measures are on your preseason assessment, that you have something to calculate your rates of infection and a way to monitor compliance with preventive methods, and to report things not only to Pacers but also to leadership and staff in a way that works well with your QAPI program. So what are those activities? Well, you want to make sure that you are using your process and outcome measures to determine the effectiveness of your improvement strategies. And you also want to look at how to measure the existence of or the extent of barriers to safe care. What's in your way making this not happen? So, and again, those reports need to go out to everybody, and we're going to talk about how to do these different types of outcome measuring, actually, and the kinds of things that you can do to measure performance. A lot of people just measure outcomes, how many cases you had, and that's the end of it. But it's important to think about how you can measure performance. If you want to do this, who's going to do it? When are they going to do it? How are they going to do it? And the administrative people have to say, okay, here we're going to make time for you to do this. So here we have an outcome measures worksheet, which is also part of our toolkit. It not only it gives you the two outcome measures, the norovirus rate of infection, or the percentage of confirmed infections, and that's people that have had the actual testing done. And the formula is right there, and you can look at this year, and then you can look at the following year and see if you did any better. We've done the same for process measures and listed a couple here that you could use, whether it's hand hygiene or contact precautions or cleaning, and all of those kinds of things are performance with how did people perform in doing and following through the protocols that you put in place. So I have something new for you as promised. With this, we're coming soon, actually, in probably June or July. We are adding to the toolkit that we have, and something I think that those of you who have to do education will really like. So along with the updated research and Pennsylvania data, we wanted to make sure that we talk a lot about education and training, and not everybody has had the time to do the research. So along with the advisories, which give you the most updated research, the evidence base is what you want to back yourself up, I also did this for you. So these materials will be published at some point on the toolkit as soon as we can get them up there. They are being reviewed right now. But what I did for you was to make you something that you could use as the trainer for your facility. Now, we have the videos and we have the YouTube video and those kinds of things. But, it's hard to remember everything. So not only do we give you the slides that we thought were important, and certainly include some other slides that you didn't see in this webinar, but also the teacher's training notes. So these speakers' notes, what helps you do that training. So hopefully you'll make use of this, and it will help you. We also have posters. Now, a lot of you have norovirus posters in your facility already that we've sent out over the years. But right now, the availability is for you to download them as flyers from the website. They're both there, the one for clinicians and the one for patients. And you can use these as handouts. The resident council, norovirus season starts to kind of get everybody ready. Get them talking about hand hygiene and all of that, and telling you if they feel sick, if they're in independent living. So in summary, the outbreaks of norovirus-associated gastroenteritis have certainly increased, not only nationwide, but we can see that we're just not making any headway in our Pennsylvania long-term care facilities. The numbers are not budging. So we need to do something different to control this because it is controllable. The experience of a small group of Pennsylvania healthcare facilities has shown us that using this preseason program can help reduce the impact of had norovirus cases and not having an outbreak. So the evidence-based strategies that you want to use need to modify the host factors, the viral factors, the environmental risk factors. So you need to prepare for norovirus season, to ensure that you have some basic outbreak control measures in place, that everybody knows how to use the enhanced precautions, and how to conduct leadership and post-outbreak activities. So the post-outbreak measurement of compliance with process measures is fundamental to help you determine the existence and the extent of your barriers to control this nasty disease. We do have some references for you. We have the 2010 advisory, because the one that we're doing now is in the review process. So that will be on the website. If you all signed up for the advisory, which you can do on our face page, it's free. It'll just come to you. These are the McGeer criteria, as well as the CDC most recent guidelines for norovirus. You can see all the science in there. So with that, I'm going to send this back to Rick so we can get started with our Q&A.
Thanks, Sharon. That was a very informative presentation that actually contained a lot of information everyone can use in their organization, regardless of the tool that they use. Sharon, I was going to ask, who should be on the facility outbreak team?
That's a good question, Rick. So we talked about the interdisciplinary program, and I think this falls right into line with the new CMS regulations that we have to have an infection preventionist who has time to really do infection prevention. But that being said, it is a team sport. So you need your administrator to be the decision maker, to develop policies and hold people accountable. You need your educator to train staff on norovirus and methods to implement their job or the department-specific protocols. They're going to do something different in dietary than they're going to do in housekeeping. Nursing needs to know how to implement the various protocols for contact precautions and resident care. Infection preventionist job is to do surveillance, gather the information to report, and to assist other disciplines as necessary because that's the person who's the expert in the building. The medical director is really essential to help with that policy and procedure development and to communicate what's going on to all the other providers. You may have quite a few of those, including nurse practitioners in your building. I think the environmental services and the laundry people want to know if there's any special cleaning protocols. So we talked about enhanced cleaning more than once a day. Laundry, if depending how your laundry is set up, they may have a big influx of really nasty-looking laundry, so you want to make sure they're using the right precautions down there. Their PPE, using masks if they're opening laundry and aerosolizing vomitus that's in the laundry. I don't want them to swallow that. For dietary, don't come if you're sick. Wash your hands somewhere else other than the food service sink, those kinds of things. Social service is really valuable. They know the residents, they know the families really well. So you want them to help you communicate to the visitors and deal with the new admission parts of this. So everybody's got a part. So I would suggest that, while some people may have, that job may be more than one person, or one person may have more than one of these jobs, that those are the people who you say, outbreak team, report to room A at 2 o'clock, and these people know who they are. Hopefully that helps.
Okay, thank you, Sharon. We have a question here. Let's see if I can. For all intents and purposes, influenza season is very clear, October 1 through March 31. Is there any official season that is dedicated as norovirus season by the CDC?
Winter. They just say winter. They call it the winter of virus. But as you can see from our slide that shows the Pennsylvania long-term care facility data, that fluctuates a little bit from year to year when that's really starting. But we do have that time period that will take you, not much is happening over the summer, a couple of sporadic cases, but it's the winter months. December, January, February are the worst, but we can still get it into March and April. So that's all they say is winter. But you can look hopefully you'll download that CDC guideline and keep that handy as part of your online library. But that's, until that changes, that's still, it's not like norovirus can happen in the summer, but we rarely have outbreaks. But it's good to practice if you have a couple cases in sometime other than winter.
Thanks, Sharon. Another question is, who should activate the Rapid Response Program?
Okay, well, if your staff is doing a good job of reporting to you, the infection preventionist, or the nursing supervisor who will notify the infection preventionist, the IP will say, oh yeah, I'm looking at this, we definitely got a potential norovirus problem. It's usually the infection preventionist who doesn't do that by herself. A lot of places, especially hospitals, give the infection preventionist a form that says that, in the event of an outbreak, the infection preventionist gets to have, the power to, close units or do various things. So you want to figure out what that's going to look like with your administrator, your director of nursing, and very important, your medical director. Who wants to get notified first? I would, in the past, if somebody said to me, called me up, as they have, I've also fallen prey to this, like, I had one of those calls, everybody over here has been having diarrhea, and I would okay, institute contact precautions immediately. And, I had to go over there to make sure they knew what that was. And then my next stop was to the administration. Because letting them know that this is starting, what I'm going to do is the IP, I'm going to be looking for cases. If I think we're having an outbreak, they'll be notifying the health department, and our outbreak team is going to have to meet. So I think it's usually the infection preventionist who kind of makes that happen. But people are still feeding that information to that IP. Have any more questions?
Thanks, Sharon. We have another question here. Should I use red isolation bags or dissolvable bags for linen for residents with norovirus?
I know we want to put everything yucky in a red bag. The reason we started using red bags is because of an OSHA requirement, and anything blood or things that are visibly contaminated with blood, other potentially infectious materials, meaning with blood in them, in a red bag. Your facility, those red bags are things that get burned. They're disposed of as disposable waste, and that costs money. So you don't really have to do that if you're handling the linen appropriately at the bedside by putting it in a bag that it's not dripping out of, by not letting it sit around, getting it right down to the laundry, and making sure they know how to take precautions while they're dealing with this mess on that end of the thing. But you do not need special laundry bags, and you can see that in the CDC guideline. Red bags are for blood.
Okay, I don't have any more questions in the queue, so I'm going to remind everybody, if you do have questions, you can type them in the Q&A box found on the right-hand side panel of your screen and direct them to all panelists, and we'll try to answer the questions now. We have the opportunity. We have a few more minutes left, and I think it's a great opportunity to take advantage of, to ask the expert in the field exactly, what you need to focus on with your norovirus program. Sharon, while we're waiting just a few more minutes, are there any other additional key points that you'd like to emphasize?
I would. I think
what has actually happened over since we, first started our toolkit on norovirus protection, and then where it's actually moved to now in its present form.
Well, the toolkit's been around for a while, so if you haven't seen it, I would suggest that You take some time to go through the toolkit. Just look at it at your leisure. There are instructions with each of the documents I showed you on how to use it. When you download it, you can also use it online. If you wanted to have an online version, you'll have to print it out and use paper and pencil if you don't like to do that. But if you have questions and you sit down with your team, say, okay, we're going to go through this checklist to make sure we're doing all this. Questions will come up, and you should know that the authority staff is here for you. You can call the main number direct and ask for an infection preventionist. You can call the help desk, and they will help you as they can or direct you to the right person who can help you. We're here all the time. It's not just when we're doing a webinar to really answer your questions, because I think these things do come up when you're actually starting to work on it or change or update your program. So just so you know, you can contact us anytime. Okay.
Actually, we have a couple more questions that have actually been filed. One is, will antidiarrheals help with the norovirus?
That's really a question for your medical director. There's no recommendations for that in the CDC guidelines. As far as treatment goes, it's usually based on symptoms. So IVs for dehydration, antidiarrheals for diarrhea, but some people can't take those medications. So you want to look at their comorbidities and work that out with your medical director. It's not like Tamiflu for everybody when you have a flu outbreak. Be patient-specific.
Okay, and then we have another question here. What is recommended for recognizing staffing outbreaks versus patient outbreaks? Staff may not report what they are calling out sick for.
Well, you need to have that worked out, again, ahead of time with your HR and your staffing. I think that staff needs to be sure that you're going to handle their calls discreetly. In the event of an outbreak, we do need to know. HIPAA is a need-to-know basis. We even need to know in the event of an outbreak. So the staffing outbreaks, use a different line listing for your staff. Keep them on a different one than your patients or your residents. So if you can see what kind of, are they coming from the same unit? Did everybody on night shift just decide to call out? It can give you some information that you want to share with the administration, director of nursing. You can take the names off, call them person number 1, number 2. Maybe only one person gets to know who they are. But what unit they work on is really important. So you can do it that way to kind of keep things private.
Okay, and I think we have time. Oh, go ahead.
Okay, go ahead.
No, I was going to say we have time for one more question, but I didn't know if you wanted to add anything
nope,
additional
I'm
to
done.
what you just did. Okay. One more question, a real quick question. When is the right time to discontinue a resident from contact precautions?
Minimum when they have been 24 hours with no symptoms. That goes for patients and staff. That's the minimum. Because that's when, but remember, people can still shed norovirus after that first 24 hours. So if you wanted to make it 48 hours to kind of drop down the burden of the amount of virus they can still shed, I like the 48 hours myself. That's kind of what I did. But we also made sure that people got their hands washed, got their wheelchairs washed, that we were really using standard precautions very strictly. Okay?
Thanks, Sharon. Thanks again for everyone who participated and for Sharon for your presentation. This concludes our webinar.
Thanks, everyone.